Good afternoon, and welcome to the 51st episode of the Royal Society of Medicine COVID-19 webinar series. This series is by health professionals for health professionals. I'm Ebere, Okereke, consultant in global public health, and I lead a UK aid-funded project, works with countries in Africa and Asia to strengthen capacity for compliance with international health regulations. And it is my privilege to moderate this special edition of the series focusing on the African experience of COVID-19 pandemic. As background, the general and scientific media coverage of the pandemic experience across Africa has ranged from very early predictions of catastrophic impact to skepticism about the persistently low numbers of cases and deaths being reported. We can just show a slide of the current epidemiology now. And there has been wild speculation about ascertainment, about protective factors, about the demography, and even some suggestions in the media about poverty being a protective factor. More recently, African public health leaders have begun to be heard about their response and their experience, and I'm hoping that this panel will help to bring the voices of those African public health leaders to our audience. So without much ado, I'd like to introduce you to our panel and to welcome them. I will start by introducing Dr. Chikwe Ihekweazu, who is the Director General of the Nigeria Center for Disease Control, and until January 2018 was the Acting Director of the Regional Center for Disease Control for West Africa. Dr. Ihekweazu trained as an infectious disease epidemiologist and has over 20 years experience working in senior public health and leadership positions in several national public health institutions, including the South African National Institute for Communicable Disease, the UK's Health Protection Agency, and Germany's Robert Koch Institute. Chikwe has led several short-term engagements with WHO, mainly in response to major infectious disease outbreaks across the world, and including the WHO-China Joint Mission on Coronavirus in 2019. And welcome, Chikwe.
Thank you, Ebere. Great to be here.
Right. Our next panelist is Dr. Magda Robalo. She's a High Commissioner for COVID-19 in charge of coordinating the national response to the pandemic in Guinea-Bissau. She's the immediate past Minister of Public Health in the first parity government of Guinea-Bissau and an adjunct professor in Griffith University. She's a member of the Malaria Elimination Board and a chair of Ethics and Governance Committee for the Global Fund to Fight AIDS, TB, and Malaria. Dr. Robalo has held senior positions in the WHO and has been WHO country representative to South Africa, Zambia, Namibia, and Ghana. And most recently, she was the Director of Communicable Diseases in the African region, WHO Afro region, leading WHO's work on HIV, AIDS, hepatitis, TB, malaria, etc. Dr. Robalo received her medical degree from the University of Porto in Portugal and has had postgraduate qualifications in Portugal and from Canada as well. Welcome, Dr. Robalo.
Thank you. It's my pleasure to be here today.
And our final panelist is Dr. Jonah Nkengasong. Jonah is the director of the Africa Center for Disease Control and Prevention. Prior to his current position, he served as acting deputy principal director for the Center for Global Health at the US CDC and chief of the International Laboratory Branch for the Division of Global HIV and TB in US CDC. He received a master's in tropical biomedical sciences from Antwerp in Belgium and a doctorate in medical sciences in virology from Brussels. He's received many awards for his work, including the Shepherd Award, the William Watson Medal of Excellence, the highest recognition given by the US CDC. He's been knighted by the governments of Cameroon, Cote d'Ivoire, and Senegal for his contributions to public health. He's an adjunct professor at the Emory School of Public Health and serves on several international advisory boards, including the Coalition for Epidemic Preparedness Initiative, CEPI, the International AIDS Vaccine Initiative, amongst others. He has authored over 250 peer-reviewed articles in international journals and published several book chapters. So welcome, John.
Thank you.
Right, so I think we'll drive straight in. And what are your views about some of the doubt and concern expressed by the lay media and some aspects of the scientific community about the persistently low incidence, morbidity, and mortality from COVID across the continent of Africa? I mean, Egypt, Morocco, Algeria more recently, and South Africa have some of the highest figures across Africa. But even in those countries, the morbidity and mortality seems to be significantly lower than is being reported from North America and the European countries. And many of our audience members have asked questions about some of the hypotheses that explain the low mortality and the low impact of COVID across the whole continent. So a couple of, I'm just going to mention a few questions that we've received directly. So Anita Makri asks, we've heard a lot of theories about why Africa wasn't hit harder by the pandemic. What do you think are the most likely reasons? Wilbur Sabiti asks, is the COVID-19 disease phenotype and lethality in Africa different from what we see in Europe and America? Peter Spencer says, why are COVID-19 rates lower in sub-Saharan Africa? Is it low mean age, little travel, prior BCG, failure to detect? John Crowd asks if there is a natural immunity to COVID amongst Black and Asian minority ethnic populations. And Janet Amake asks, does hydrochloroquine play a role? Dr. Ngozi Uduku asks, is vitamin D associated with the low incidence? So these are examples of some of the questions and the hypotheses that are being considered to explain the epidemiology of COVID-19 across the African continent. So what is the true picture? What are your views? So John, would you like to kick us off on that?
No, thank you, Ebere, for including me as part of this conversation. I think today we are marking a milestone in the pandemic or the epidemiology of the COVID-19 pandemic in Africa, with a little bit over 2 million cases reported across all 55 member states, and that is a significant milestone. What we know about COVID in Africa is the facts, is that the member states have done extremely well. I think in some of the assumptions and speculations that I heard, I didn't hear anything about the response being effective in several member states. I think I'll start first of all by congratulating my colleagues who are on this panel, Chikwe and Magda, for the extraordinary leadership that each country has demonstrated in fighting COVID-19 in Africa. I think because of the structures like the Nigeria CDC, the National Public Health Institutes across Africa, we've actually demonstrated that the efforts that have gone into building our response capacity has really been used effectively during these very challenging periods. The second thing is really the political leadership of our continent. The continent has come together like never before at the level of the head of states. President Cyril Ramaphosa, the chair of the African Union, has convened about 8 meetings of head of states to really look into COVID, define strategy, develop a joint approach in responding to this. I think people like Chikwe and others are all working together with us to form a task force since the beginning to work as one unit on the continent. So those factors really played a very important role on the continent. And no one ever questioned the need, the value of wearing masks. When we started this and advised the citizens, everybody aligned. We may be seeing a trend where people are beginning to ease the use of masks, which is really not what we should do. But at least early on, there was never any doubts, any controversies that the fact that you could lock down a city like Lagos, and I'll let Chikwe speak on this. You could lock down a city like Johannesburg in Africa to fight this, showed extraordinary courage, okay, and political risk that the leadership took to fight this pandemic. So I think when we look at the numbers and we all make our assumptions there, I think there's always a lot that we don't know. When you count things, you obviously will miss out things, but when efforts are deployed in a coordinated, collaborative, and coordinated fashion across the continent, they should also be acknowledged. So I'll leave it at that. I'm looking forward to more conversations around this.
Thank you, John. That's a very whistle-stop tour of the way the continent responded collectively. So I'll go to Magda specifically. As Special Commissioner on COVID to the President, you have a specific role in the connectiveness between public health and politics. So what is your view about how the politicians have responded to the pandemic? And what has been the role of scientific and public health advice in that response?
Thank you very much for having me. And I think this is an important conversation. Politicians understood immediately that this was not just a health issue, but a political issue, and they took the measures that were required at the right time. As John said, the coalition of politicians in our continent really showed leadership. 18th of March, the borders of my country were already closed. It was too late because already we had someone who came from abroad who infected, passed on the infection to some people. But that was an audacious attitude from our politicians. Even putting up a commission to specifically dedicate its efforts to fighting COVID was a political decision that we should acknowledge, being an act of courage and discipline from our leadership. It has been difficult to live with lockdown measures given the fragility of our economies, even though we had terrible shutdown of our economic prospects and growth for 2020, 2021. The politicians took that risk and closed the borders in order to limit the transmission of the pandemic. From that moment, and on a continental level, like John said, there was a leadership that we should commend. I should also say that among the things that have contributed for reduced transmission in Africa is the resilience of our continent. Despite our weak health systems, despite the fact that our health information systems don't capture all the data that we need and how we should have it in a timely and complete manner, despite the fact that our laboratories were not so well equipped, we have been dealing with pandemics, with epidemics and outbreaks throughout. So it has become, unfortunately, a feature of our health systems to quickly organize, plan, and go to the field to combat an epidemic. And everybody's memory go back to Ebola of 2014, 2016. And that has been very helpful for Africa during this COVID pandemic.
Thank you very much, Magda. And that moves me smoothly on to a question I wanted to put to Chikwe. Nigeria is the largest country in terms of population on the continent, over 200 million people, huge, complex country with a federal system of government and extensive global connections. This is not the first time that Nigeria has defied expectations. There was anxiety during the West Africa Ebola outbreak that if it was seeded into Nigeria, it would be impossible to contain. And once again, we're seeing that Nigeria seems to have managed to respond. Jacqueline Bweyame asks, what do you think made the difference to Africa not being as affected at the level that had been predicted? And I'll put that to you. What was your role? What was the role of the organization that you lead in the early response? How did you respond to the early news about the pandemic? What have you been doing since?
So thanks, Ebere, and thanks for having me on this panel. I think maybe we should start from the premise that maybe our expectations were wrong. Mm-hmm. Why would you expect a doomsday scenario in Nigeria or Africa all the time? And I want to think that if the tables were turned, actually, and we did have an explosive outbreak in Nigeria, nobody would be looking for alternative hypothesis for why that is the case. We would all have been hammered for being incompetent, naive, and unable to manage our own backyard. So whenever we seem to just do slightly better than people expect us to do, we are all scampering around looking for an alternative hypothesis. So it's something we will get to at the end of this outbreak. I think it's too early to start dealing with that in detail. Yes, there are lots of unknowns, but there are also lots of knowns. And we're going to study them in detail. We've already started. The evidence seems to suggest that there's no difference in the virus circulating in Europe versus the ones circulating in Africa. We've been very proactive in using genetic sequencing to look at that. There might be other immunity factors, but that will take some time to study. But the one good thing, if I might call it that, when you've had multiple infectious disease outbreaks, is that you do learn how to deal with them. So we actually have a public health workforce that is very adept in lots of the basic things we need to do in public health. We do this for Lassa. Unfortunately, we still have that yellow fever and a few other of these diseases that have disappeared in many parts of the world. Our population, socioeconomic realities, climate, population density really make Nigeria and the West African coast really an ideal place for the emergence of infectious disease. And with that has come some expertise. We have a field epi training program that is now in its 12th year, has graduated over 400 graduates. We've built this National Public Health Institute that is now developing capacities in various aspects. And I think those must have contributed to some extent in where we are. But we are by no means out of this. And we have to just, like John rightly said, really keep our eyes on the ball. We're 10 months into this. The impact of the shutdowns across Africa. I mean, if a country in the West shuts down, more or less they're able to manage. But the impact, the economic impact on the shutdown in Nigeria will be felt for years to come. So we have made huge sacrifices in our countries in order to protect our population. And I hope that pays off in the long term as we slowly start our recovery with the hopes on the horizons around tools that might give us a few more opportunities in controlling spread.
Thank you very much, Chikwe. Thanks for that very robust response to some of the I think what we'd say is a lack of acknowledgement of the efforts and the developments across the continent in public health. But there are some genuine realities in that there is a limit, that there are some restrictions in access to diagnostics, to PPE. The shortage of PPE was a very new experience for many higher income countries who have a practice of just-in-time supplies that have always worked, but limited access to diagnostics and therapeutics and medical devices is not new for many African countries, unfortunately. And no doubt the global scramble that we saw earlier in the year to acquire diagnostics reagents, PPE supplies for the countries who had more access to money would have created additional challenges for the African continent and African countries. One of our audience, David Wingfield, asked, is the capacity for testing limiting the management of the epidemic? And John, I'd like you to sort of maybe respond to that and talk about some of the continental initiatives and how Africa CDC has played a part in that.
Thank you, Ebere. And that's a very valid question. And let me try to respond to that in two ways. One is that as a continent, we have to start learning or documenting some early lessons. I think lesson number one is that we have to rely on our own proper means in developing diagnostics. I underline the word developing diagnostics so that we are not reliant on externalities. When COVID hit, when COVID was identified in China, it took just 2 weeks to put out the sequences. And the rest of the world, many countries use the sequences in developing diagnostics, which were extremely important in helping them for their testing and contact tracing and managing the disease. But we had to rely entirely on outside forces to provide us with diagnostics. And it's not difficult to manufacture a molecular test. If you design the primers and probes, you can do that in-house, and then your challenge becomes, how do you scale that? I think the number one lesson is that we ought to, as a region, promote the development of local diagnostic capacity. And I'm very pleased that countries like Nigeria, Senegal, Morocco, South Africa, Kenya are now developing diagnostics for COVID locally. And I hope that that will continue. As a continent, I always quote these statistics. We've lived with HIV for 40 years, and each year we conduct about 100 million HIV tests, but there's no country in Africa that develops or manufactures a simple rapid test. I think that we cannot continue to talk about health security without basic in diagnostics. So I think, so that is one, just looking at it from the higher level. At a more micro level, when COVID hit the continent, we had a sophisticated laboratory capacities, but no reagents for that. And I think I want to make a difference, because the narrative is always that the continent had no capacity to test for COVID. No, we didn't have the reagents to test for COVID. I mean, there are wonderful labs across the continent, but they were just not there. And but what happened is that it wasn't just for the continent, but it was a global shortage and a global scramble and panic. So the world panicked, and they went to scramble, and the whole concept that we've been preaching about global health security, IHR disappeared. I think we threw that out the window, and everybody looked inward to protect their own countries. I think we should learn from that experience very early on. I know we are only 10 months into this, but there are some early and emerging lessons that we should learn.
Thank you, John. And you mentioned IHR, and that seems to be a natural move to my next question. And Magda, I'd like you to kick us off on this. We've seen a lot of blame laid at the foot of WHO for perceived poor coordination and delay in response to the pandemic. And efforts have already started to review the international health regulations to see where the flaws or its limitations and how it can be improved. You've worked with been a senior director in WHO in the Africa region, and as an advisor to national governments. What is your reflection? How has WHO performed? And what are the limitations of the international health regulations as you see it coming out of this response to COVID? Magda, what do you think?
That's a very important question. I think every time there is a global health crisis, WHO goes through closer scrutiny, which is okay. But I think it was too early in the process to start accusing WHO of poor coordination of doing little for the extension and the dimension of the pandemic. There is an assessment going on, and I think we will learn our lessons. There is always afterthought attitude that we have. We tend to forget that WHO is underfunded, and WHO is as strong as its member states. WHO depends very much on the decisions that are made by the member states at the World Health Assembly or the Executive Board, and it depends on member states to actually fund the work that will make WHO stronger and give it the power to command and decide on some of the things that affect the life, the health of the entire world. I think the international health regulations were put aside because self-interest, nationalism comes first. Every politician tends to protect its population. That's why they are elected. That's why they are there. I think we, in the aftermath of this pandemic, we need to go back to the IHR 2005 and really sit down and have frank, probably uncomfortable discussions, and then see how, if the next pandemic comes, or probably the question is not if, when it comes, what it is that we are going to do collectively so that there is an equitable share of resources, so that less fortunate countries in terms of economic development are not penalized because of the position they find themselves in. I think the political economy of this pandemic needs to really be studied, documented, researched. We need to learn lessons not only on the front of how many billions or trillions have been lost in terms of economic development, but is so important. We tend to think that we need to manufacture the products of our agriculture. We need to transform and export rather than exporting raw material. The same applies to health. We need to be able to produce our own masks. We need to be able to produce our own reagents. He mentioned the example of HIV, and I think when the dust settles, we need, and I look at Africa CDC to lead this conversation and lead this work. Africa needs to do better in terms of getting us prepared for the next pandemic, because we know it is going to come, we just don't know when.
Thanks very much, Magda. Chikwe, I'd like you to comment. You were part of the WHO mission to China early on in this pandemic. And can you share with us some of your reflections from that visit?
Yeah, thanks, Ebere. You know, that was just an incredible mission if I think back to it now. And I think for me, the biggest lesson I learned out of it is, you know, a lot of what we've done in response to this outbreak has been driven by what China did very early on. And that term, lockdown, right? Where they basically locked down big chunks of the country, more like a continent. And so many countries have tried to do the same. But what never gets through is what China did in parallel. So yes, it locked down most of its country, but it also had the this organization within their society to deliver food, commodities, medicines, funds across the entire Wuhan province, you know, which is about just a little bit smaller than Nigeria. So a lockdown cannot work if you don't have the infrastructure to do the same. And really reflecting on it, it was the first thing I thought when I got back to Nigeria, that we can't do this. So when I advised our government on what to do, at the time we were implementing the lockdown in Nigeria, and if you remember, we already said from the very first speech of Mr. President that we were going to start easing that lockdown gradually a month later, and then through various stages, because, you know, the purpose of the lockdown wasn't necessarily to break transmission, but to enable us further prepare, buy us some time in order to prepare. So that's one thing. And I think, you know, we on the continent have a very Western gaze. You know, this is driven a little bit by the TV channels we watch, where our historical relationships are derived from. But I think there is a lot to learn from the eastern part of the world. Not everything, but there's a lot to learn and to pick up pieces with which we can then organize our societies. And one important one that was a big issue for me was on, even when you did have a lockdown and you wanted to distribute food, commodities, whatever, you know, we lacked the systems in Nigeria to do that effectively. We lack the registration systems. You know, public health cannot work if you don't have good population registration services. So there are many things that I hope we can now come back. These are not rocket science, build back in our country. When people talk about building back, they think about big infrastructure projects, but I really think about systems. Just like we've been focusing on health security, there are many other kind of systems that we need to really focus on, and that's really what we are committed to doing at NCDC and in Nigeria with our national partners.
Thank you very much, Chikwe. And you mentioned logistics, which it seems to be a perfectly natural transition for us into discussion of the situation with vaccines. So with the recent good news about the indicative effectiveness of the Pfizer biotech and now the Moderna vaccines, thoughts are moving, of course, to how we're going to be able to use, or whether we're going to be even have access to these vaccines, because there are reports that the richer countries in the West have already bought up more than 3/4 of the expected vaccine supply. John, you called a conference in June this year, very early on, one would say, to discuss Africa's needs for a COVID vaccine and how to ready African countries for mass vaccination programs. Now, logistics has already been flagged up as a challenge for us generally. This will be a particular issue with these vaccines are being reported to require -80 temperatures for storage. And more particularly of relevance here is that we'll be looking to vaccinate a different profile of the population than we're traditionally used to. where the largest vaccination campaigns we've had in recent years around polio, for example, are targeted at children. Most of our immunization programs are targeted at children. The expectation is that the need for COVID vaccine will be at the other end of the age spectrum, and particular subgroups are particularly vulnerable. So do you think we have the ability to use these vaccines? What can you, Africa CDC, working across the continent with public health leaders and politicians do to prepare us for a vaccine? And of course, please do touch on actually how we get access to the vaccine. And I listened to the webinar in Chatham House this morning about the COVAX program. John?
No, thank you, Ebere. I think the continent has reacted or prepared itself for this conversation since June 24th and 25th. You, Chikwe, were all part of a meeting that we convened with, again, the strong leadership of President Ramaphosa as the chair of the union, strong leadership from chairperson of the African Union Commission, Chairperson Faki, a whole host of ministers. And we knew, I mean, at that meeting, if you recall, the mantra was that this is a meeting for our future of the continent. So, and subsequently, we developed a strategy, a vaccine strategy for the continent, and which was based on 3 pillars. One was that we have to take part in clinical trials. And I'm pleased that some clinical trials are taking place on the continent. We continue to advocate for that, support that. Second pillar was the financing and acquisition for vaccines, which we are working with the private sector. And just two weeks ago, President Ramaphosa put together a task force, including chairperson of the African Union Commission, Strive Masiwa, myself, and others, to engage and to use his word, go out there and be bold and be unapologetic and get vaccines for Africa. And we are working on that. And with the Afro-Exim Bank President Orama. And the third pillar is the delivery and preparedness, which we are working very closely with the World Health Organization, UNICEF, to develop guidance, which will be issued out shortly so that we can start preparing the countries. I just want to be sure that we have a cautionary note here. We have, Africa has to recognize and really appreciate the COVAX facility, because that is a mechanism, a true mechanism for solidarity, a true mechanism for multilateralism. At the same time, we have to also be thinking of our own targets and goals that were expressed in that strategy. That strategy calls for immunization of up to 60% of our population to achieve herd immunity for a continent of 1.2 billion people. We recognize that through the COVAX facility, as a continent, we are promised about 23% of vaccines. So we have a gap there to achieve our strategy. Remember, we have a marching order from the leadership that says, go out there and do what is right for the continent. And I think we are looking for the right partnerships there. The Afro-Exim Bank is ready to leverage up to $5 billion, and they are committing to that to support the Africa's initiative to acquire vaccines. We are in discussions with several bilaterals, including the Serum Institute in India, to look for additional doses of vaccines. That will be the same vaccines that are in the COVID pot of vaccines. I mean, with the same criteria of safety and effectiveness. Now, the question with respect to the current vaccines, that the two vaccines that were announced last week and this week, I think the first thing is to celebrate the good news. I think it looks like we will be able to have an effective vaccine against COVID-19. My hope is that in the coming weeks, many more breakthroughs will be announced, and then the conditions for delivery will be important. I think we also recognize that it's one thing to have a vaccine. It's one thing to be able to vaccinate the population, so that we don't get into the valley of death. So the distributing vaccines, storing them at -70 for a continent like ours, I think it will be a big challenge. We have to face that reality. And I think we also have to admit that we cannot really live with the memories that there will be people watching TV images where vaccination is occurring in Europe and the United States, and we on the continent are not vaccinated. I mean, such a scenario is not hypothetical. It is a reality that has happened before. In 1996, drugs against HIV were introduced in the Western world. They used to cost $10,000 per patient for a year. It would take us 10 years before they were truly accessible on the continent of Africa. And between 1996 and 2006, 12 million Africans died. And I was at that needlessly because of the lack of access to antiretroviral therapy. So this conversation is a real conversation that the African Union and the leadership at the head of states level is taking seriously. And I think, and we are taking this seriously this time with money in our pocket. We are saying we can leverage up to $5 billion from the Afro-Exim Bank and work with member states to secure enough vaccines for the continent.
Thank you very much, John, for that very comprehensive description of the cooperative and coordinated response to sort of learning from past experience that we are not falling behind. In addition to the challenge of actual access in terms of finance, the logistics of dissemination, there is also a need for us to address the issue, which is not an African issue, it's a global issue, and that is around vaccine hesitancy, linked to often a lot of misinformation on social media and in the public around how the vaccines are being produced, and skepticism about the speed and therefore perceptions about risk associated with these vaccines. So it's one thing to sort out the actual access to the vaccine, to get the logistics to actually disseminate it, have the infrastructure to be able to get the vaccine to the people who need it, like Chikwe touched on. The Chinese response isn't just about the lockdown, it was about the system that supported that lockdown. But we do need to address the issue of vaccine hesitancy and skepticism across the continent, globally, but for the purposes of this session, across the continent. One of our audience members, Hiba Malik, asked, how do you feel about the vaccinations being made in Africa before European countries who were affected first? We also had a question for somebody who reflects on many months ago now, it feels like a whole lifetime ago, the suggestion by some French researchers about piloting and testing the vaccines on African countries, citizens first, which has created a lot of anxiety. How are you addressing misinformation in the broader sense, both in terms of the vaccine, but about the vaccine, the disease itself in your countries and across the continent? And I'll put this question to both Chikwe and to Magda, but Magda, if you could lead us off first.
That's an important, extremely important question, and that's going to be a major challenge to all of us. I think the language, the theories, the myths, the rumors, and the dichotomy that has been unprecedented during this pandemic, where the global South, which was expected to be massively affected by this pandemic, actually wasn't. So the logistics, the financing for delivering the vaccine will be as important as the communication, the social mobilization, and working out the we need to deconstruct the messages and the beliefs that people have acquired since January, since February, March, when the first cases came into the African continent. If we don't work hard on social mobilization, on making people believe and acknowledge the benefits of getting vaccinated, we will fail the vaccine program against COVID. And this is an important leg of this whole process of fighting the pandemic that we can't miss. This is a fight we can't lose. It will depend from top down or from the bottom up on a very well articulated communication for us to get our people to believe that indeed the regulatory mechanisms of our countries are there to work for them. We are going to make everything it takes to ensure the safety of vaccines that are proven to be efficacious, and we will not compromise the quality for the African continent. I think that message is important, it's needed, and it has to be strongly supported across the board from the African Union down to the leaders in our countries if we have to achieve the mobilization of our population to accept to be vaccinated. We have seen what's happened with polio when all the conspiracy theories and vaccine hesitancy moved across some countries in our continent. So we really need to be ahead of this problem for us to succeed. We have done well so far. We need to close the chapter of this pandemic doing well on the vaccine part. So to me, it's social mobilization, strong communication in one voice. People need to be assured that we will not leave one stone unturned to ensure that only safe vaccines, only efficacious vaccines are delivered in the African continent.
Thank you.
That's my take on this.
Thank you, Magda. And Chikwe, just briefly, I was in Nigeria last month, and I met people who actually said there is no COVID. It's a Western conspiracy, and I'm definitely not going to have the vaccine because it's an experiment on us. What's the strategy in Nigeria?
So Ebere, thanks. I don't think there's one strategy that is different from everywhere else, but let me say a few things that we have done that I think will help us address this hesitancy issue globally and in Nigeria. I think one thing we've done is, you can criticize our leadership for many things, but I think he has allowed us the space to have a consistent voice of authority speaking about this outbreak from the very beginning. He delegated this authority to the highest level of government, to the secretary, to the government of the federation, set up a presidential task force, trusted his Nigeria Center for Disease Control, and with all these voices speaking together for the past 10 months, I think we have gained some level of confidence in the Nigerian population to be able to then use that when it comes to then asking them to take the vaccine or not. And so I'm hoping that there will be some benefit in that. But I think the other thing that is affecting all of us is a little bit the global situation. When we sit back here and look at how countries are competing for doses, based on affordability and ability to pay and buying up stock, we wonder whether really this is the world we want to aspire to be. They say we are developing countries. If that is what it takes to be developed, which then means that countries are, really competing for vaccines like the, luxury items, like commodities. It's astounding. There must be a better way to procure vaccines and essential commodities during a pandemic where everyone is affected, irrespective of your national boundaries. So yes, we can address this through our voices nationally, but I look forward to a world where we have some more global leadership and consistent global voices saying we must learn something from the HIV pandemic that John alluded to. We must learn something from all the mistakes we've made to organize ourselves better when there's a public health crisis.
Thank you. And we are out of time, but we have one final question that I'd like to put to all of you. Amrita Chandra asked, she says, incredible panel with really powerful insights. Thank you. She's interested to learn more about what should be done, the international community should undertake to support African countries to be more self-sufficient in developing their own healthcare tools and sustainable scientific support that enables independence as opposed to dependence. I mean, John, you've already touched on that. Chikwe, you've also touched on that, as has Magda. So rather than answering Amrita's specific question, I would like you to give me briefly, because we are over time, what is the message? What's the key message about the African experience of COVID that you would like to leave our audience with? And if I could start with you, Magda, briefly.
My message is really we should trust on our abilities and capacities capabilities to face major challenges and overcome them. I think Africa is no longer the continent which will desperately sit and wait to be helped. We can find in-house domestic solutions. We have the energy, the power, the leadership, the intelligence, and the capacity to confront our problems. We may not have the means, and we need to work on them because we have the natural resources to be able to work on them. But essentially, we need to trust ourselves. We need to trust our countries, our continent, and we need to believe that, yes, we can do things, we can fight pandemics and succeed. Thank you very much,
Magda. Chikwe.
Yes, the one thing I think out of Africa really is the emergence of the Africa CDC. You know, if you think back to the Ebola outbreak and how we responded, you know, all trying to leverage our own small resources, you know, it was very inefficient. But I think since the emergence of the Africa Center for Disease Control and really John's leadership thereof, you have seen the coordination that happened at the very beginning. The coordination happening now, pulling yes, we don't have a lot of resources, so we have to manage what we have the best way we can. So if there's one message I think is you know, solidarity between countries is extremely important in times of a crisis. And there's no better example of this than the work ACDC has done for us in Africa.
Fantastic. And that naturally flows to you, John, to have the closing word on this.
No, thank you, Ebere. I think that two things that I'll try to leave the audience with. One is that we really will need to have a courageous and uncomfortable discussion around implementation of IHR and be humble and honest with ourselves. When in April, the rates of infections were decreasing in Europe, African countries, only 4 African countries were put on a list for countries that can travel to Europe. And don't forget that all our infections in Africa came from Europe. So I don't think we have to address that balance of power to say that do we have, as a developing country, as Africa, have the power to tell the global north that you cannot come to our countries, and that is accepted as part of the IHR. I think this whole discussion, that whole behavior really puts us at a very delicate position. So I think that is one. Second thing is that we really have to look at a new health security architecture that calls for a strong WHO, an empowered WHO, but also looks at regional structures in a very deliberate manner and see that as very, very complementary, and then look at national structures. The very basis of our health security should be the ability to strengthen the likes of the Nigeria CDC and others. Without the kind of leadership that Nigeria, CDC, and others put in place, it would have been a catastrophe in a country like Nigeria. We look at it today, and it's almost like it's a given. No, but it took hard work, strong coordination from a national institution like Nigeria. So I'll leave you with a new public health architecture that is underpinned by a national health security, regional health security, and a global health security.
Thank you very much. And on that note, I'd like to thank all my panelists, Dr. Chikwe Ihekweazu of Nigeria CDC, Dr. Magda Robalo of the Presidential Advisor on COVID in Guinea-Bissau, and Dr. Jonah Nkengasong, the Director of Africa Center for Disease Control. The recent epidemiology is suggesting that COVID numbers are beginning to go up again in parts of Africa. In East Africa, Kenya and Sudan in particular has been suggested, and in some parts of North Africa and in West Africa. So it isn't over yet. I'm hoping that the successes that we've seen so far will be built upon. And if we have an opportunity to bring this panel back in a few months' time, that we'll have more good news to share. And I am really sorry there were so many questions that we had that we weren't able to address. I hope that the panelists have at least provided some information, and we will put some links to some reference material with the uploaded version of this session when it goes up on the RSM website. I'd like to thank the President of the Royal Society of Medicine for allowing us to, supporting us to run this special panel. The recording of the session will be available shortly on the RSM YouTube channel. The next COVID-19 session will be next Thursday, same time, and it will be an end-of-month wrap-up. The panelists will be Peter Openshaw, Trish Greenausch, and Walter Riccardini, and we hope you can join us for that session as well. So once more, thank you for joining us for this session. Apologies for running a little over, and thanks once more to my panelists, because I all know you were double booked today. Thank you very much. Have a good afternoon, everyone. Bye.